reduction in articular or periarticular adhesions, and maybe normalization of hypertonic muscle by reflexogenic effect, maybe, right? This takes a look at kind of the fascial interface between the muscle fibers, this idea that you develop adhesions, right? I had the opportunity, I've spent 15 or 16 of my years here working directly for neurosurgery here at Columbia, and so I saw an awful lot of tertiary care with, with different nerve issues and so forth. And you'd actually see in the surgical images, you'd see adhesions of the nerves. They'd have to pull it off the disc, and there would be an adhesion to the disc where there was an inflammatory process, right? Change in length of connective tissue, plastic deformation of collagen may improve motion. And there are Bialowski's kind of done some good work in this regard. Some of you may have seen it. It's published a lot in JOSPT and some other journals. And there's some good work in this regard that's out there now. A lot of it's speculative, honestly, rather than, actually controlled studies, but they're hard to do, to be fair. Some other theories that have been proposed are improved synovial fluid movement, right? So if you can move the synovial fluid, you can then provide nutrition to a joint, right? Altering positions of articular surfaces, the relationships, and transient or perhaps permanent changes in biomechanical dysfunction. So let's just take a look here, and believe me, this is, I do recognize that that's the cervical spine we're looking at there in cross section, but it's useful because you can see here the meniscoid in the joint itself, in the facet joint. It's an extension of the capsule, right? We often find extensions of the capsule have what? Attachments to muscle. This has attaches to multifidi, like the rectus femoris has attachment to your anterior hip capsule, right? It makes sense. If I'm going to flex my hip, it's really useful to have a muscle that'll clear the capsule out of the hip as I flex it. The multifidi are most active when you do bilateral upper and lower extremity extension, going to the earliest work of Carolyn Richardson. They're not necessarily functioning the most as stabilizers, but you get the largest EMG activity. So it makes sense as an extensor that you would clear the capsule out of the joint before nipping it, right? And this is taking a look from the work by Evans above, who is looking at this effect, and it's actually from Bogduk, and it's looking at the effect of the meniscoid in the capsule, and it's showing in A, the patient flexes over, right? As they flex over, you can see the capsule distend slightly at the facet joint. That's what we're seeing here. Okay. Right. As they go into extension, they return from flexion. For whatever reason, that meniscoid gets trapped, right? And doesn't return into its normal position within the capsule. That's that little piece at the very top there. So here you see it clears as you go into flexion, you return to extension. Maybe you're rotated and flexed at the same time and you come up without derotating, right? And it potentially gets captured. The idea of manipulation for this trapped meniscoid would be to open that area, right? And then to allow it to return to a normal state. So this was proposed by Bogduk, Nikolai Bogduk. I couldn't figure out how everyone's asleep. So there's nothing like, right? I can't tell you how many patients love it when their back cracks, right? Oh, boom, right? And they love it. I actually had the experience recently where I had thrust this woman a number of times in a thoracic spine. It's helpful for her, right? And then I'm also, to be fair, motor control. I re-educate her once I thrust it and work it with extension and so forth. But at that occasion, I did it, and my knuckles cracked, right? Underneath her, like a fist onto my right. And she was like, oh, that feels so great whenever you crack my back. So I figured in that case, I should go with the effect there, the placebo effect. Timothy Flynn and Julie Fritz and Whitman and Robert Wayner did this study, and they said you don't really need a pop, right, to get the effect of the manipulation. On the other hand, there is some work, and you see that again from the work there of Evans, right, that actually people do respond to the cavitation, whether it's psychological or whether it's a release of endorphins or so forth. We're not clear. But I think we all know that basically what happens is, right, it's like opening a jam jar. You change the pressure in the joint. A bubble forms in the synovial fluid, most likely nitrogen, and it pops. And there you go, and that's your sound. And then there's some other things that happen in terms of release of endorphins and so forth. Additional report of neural effects on spinal manipulation, changes in somatosensory processing, motor reflexogenic responses. I'm really not sure. And I've spent a lot of time. I had the pleasure of spending time personally with Vladimir Janda before he died, and spent a lot of time thinking about things like reflexogenic responses. And I really don't know what that means. But it's like one of these things where the word's a little bit complex. And so it's like, you know, there's a, what did I read once? If you tell somebody that's 1,277 feet and 0.725 to the moon, right? They'll nod their head and agree with you. But if you put a wet paint sign on the wall, everyone will touch it to see if it's wet. And so I do think there's this complexity bias. Central motor excitability, motor neuron activity, neuroplastic brain changes. I guess the brain is plastic, right? It does certainly change. Hoffman's reflex response and sympathetic activity and central sensitization, right, are all other reported neural effects of spinal manipulation. And this is just looking at, I don't know what the heck we're looking at. This is looking, and you see a lot of these biological, something as well, as kind of what's happening. We know there are responses, right? The dorsal horn, the afferent information is coming through the dorsal horn, the spinal cord, right? And just like they talked about Melzack and Wake and Wool gate theory, Dr. Rosa spoke about that. This idea that there may be a flood of information, but also that there's this a cortical downward regulation that may occur, right? And so what are you affecting here? And there are these proposed mechanisms in terms of gate closing, right, in response to manipulation, descending of pain inhibitory pathways, right? So you set off a mechanism and it causes descending path inhibitory pathways, autonomic activation. So these are all these proposed mechanisms. And honestly, they're not researched. They're reasonable proposed mechanisms, but they're not well researched. So I'm not so much saying, I'm saying a little bit about what we know and a lot about what we don't know. There is some understanding of mechanical force of spinal manipulation does trigger a chain of neurophysiologic reactions. We have seen that. We've seen changes in blood vessel diameter. We've seen changes in pain responses, or even some hormonal changes. It does stimulate peripheral afferents, not surprisingly. If I smacked you on your back, it would probably stimulate peripheral afferents as well. So I'm not quite sure if, right, how important that is or not, and alters centrally mediated supraspinal. I've treated a number of physicists who interpret functional MRIs. They work with the psychiatry department, and I was on campus here for a long time. And many of the physicists who actually do the mapping of functional MRI, they say it's incredibly complex. It's rare that a PI does it. And they also kind of call into question whenever very conclusive results are made from the functional MRIs. And since they work with it much more closely than I do, I tend to take some of their skepticism on. Proposed neurophysiologic side effects include pain reduction through inhibition of nociceptors. There is some evidence of this based on kind of pressure, pain pressure threshold studies. And increased muscle recruitment after manipulation can alter spinal stiffness and muscle activity by Julie Fritz in 2011. And there has been some studies, I don't know if you've seen it, you do a thoracic thrust manipulation, you measure lower trapezius pre and post, and you see a change, or you measure glute medius pre and post, and you see a change. It does call into question what strength is. By the way, I think we're naive about that. We exercise a patient for 2 weeks and they're stronger. And yet if we biopsy the muscle, it wouldn't have hypertrophied. So what is strength? And maybe there is a neurophysiologic component to strength as well. And I do think this is important, and it's not opaque. I think it's there. You have the cutaneous receptors, obviously, through the skin, which feed information to central nervous system, right? If you go back to the work of Barry Weick and others, there are 4 different kinds of articular receptors in our joints, right? I don't know why it's so, you know, you study orthopedics and you say it's all about the articular receptor. Someone swells and it inhibits muscle activity. Why? It's articular receptors. You do a manipulation, the articular receptors will, some are inhibitory, some are activate muscle activity, right? It's part of what we study, but somehow it's not part of what we study. So there are 4 different articular receptors within the joints, right? And when you manipulate a patient, they fire, right? And that information goes into the central nervous system. What it means exactly is still up to debate, but it does happen. And then I think there are Golgi tendon organs as well as muscle spindles. And I think it's important that we don't group them together, frankly, because one is inhibitory and one's facilitatory, right? One is much more prone, GTO is much more prone to fire in response to a muscle contraction, whereas a muscle spindle fires anytime it's stretched. So they are different, and it's important we don't group them, but they are within the muscle and tendinous unit. So it leaves us, where are we on the research, right? The question is, there are two kinds of trials here, and it's explanatory trials and pragmatic trials, right? The one is, kind of what I've looked at, the biomechanics and under ideal conditions, right? And does it work we set up the conditions, we have a machine that gives an exact amount of force, an exact amount of time, and what do we find, right? On the other hand, that's never what we do in the clinic, right? Which speaks to the pragmatic trials. Does the treatment work in the real world? Right. The problem with pragmatic trials is they sacrifice internal validity for external, right? So they're not, the methodology is not good, we're inconsistent, the reliability isn't great. And the problem with the explanatory, right, is they sacrifice clinical applicability, right? So some combination of both. So the key points, right, of existing trials, a greater proportion have implemented designs geared more towards efficacy. So the ideal rather than the practical, given the heterogeneous nature of low back pain and the degree of individualized clinical decision-making required for patient care, we need more pragmatic methodologies. Even the seminal study done by Flynn and Associates and later reproduced by Childs and Flynn and Tony DeLitto, right? It's patients who responded to manipulation, patients who had less than 16 days of pain, with no pain below the knee, right? These conditions that don't apply to most of our patients. And the current literature may not be fully relevant or applicable to us as clinicians. So what I would argue here is we do understand tissue mechanics, and at the least it's incumbent upon us with our understanding of tissue mechanics to apply tissue mechanics to what we do and have a rationale for why we select one manipulation over another. Because that exists, and so not to do that is in some ways not negligent, but moving in that direction. Thank you.